sent to physical therapy. And then there's already that buy-in of, okay, they found that this was what was wrong with my vestibular system. That's why I'm going to physical therapy. And now we get to jumpstart right into, okay, you're dizzy. This is what was found on neurodiagnostics. And this is our next approach of what we have to do.
Hello and welcome to Dizzy World. Dizziness and vertigo are among the most common complaints in patients of all ages to their doctors, and yet there are still a limited number of specialists equipped to evaluate and treat these conditions. As a global leader in the science and business of equilibrium medicine, our goal is to empower healthcare providers from all specialties to help this important population of patients. On Dizzy World, we'll highlight outstanding clinicians, scientists, and business owners bringing excellent care to dizzy patients globally and living the AIB motto, dizziness and vertigo. You don't have to learn to live with it. Hello, everyone, and thanks for tuning in to Dizzy World. This is episode 3, and today we've got a very, very special guest. I'm super excited about our segment today. We've got Ali D'Alessandro, Doctor of Physical Therapy, neuro-certified specialist, and all-around incredible human being. One of the things that's really nice about this episode and with Ali is she is actually an AIB staff. She's part of our education faculty. She's the director of our rehabilitation department, and she has extensive experience treating neurologic conditions, vestibular conditions, and really lives this motto that we talk about of dizziness and vertigo. You don't have to learn to live with it. Every day. So, Ali, welcome. Thank you so much for joining us today. Could you start by just helping our listeners kind of get a quick background of you, getting to know you? What's your story? What got you into physical therapy, vestibular patients? Give us a little idea of who you are and what your practice is and some of the unique things about you.
Yeah, for sure. Thanks so much for the introduction. So I've been in physical therapy now for about 12 years, and I actually went to physical therapy school at the University of St. Augustine and started off my career working in inpatient rehab. So a lot of my beginning years was working with spinal cord injury, stroke rehabilitation, traumatic brain injury. I completed actually my neurologic residency program here in Florida at a hospital called Brooks Rehabilitation Hospital. And that's where I started really getting in depth with neurologic rehab, and then later sat for my board certification and got my NCS. After that, I transitioned and I still worked through outpatient rehabilitation, and that transition was still with a lot of neurologic PT with traumatic brain injury, stroke rehab, and SCI as well. And of course, intermixed with that and those patients with all those comorbidities, I saw a lot of vestibular rehabilitation overlapping with these complex medical cases that we were seeing. And so my experience with vestibular rehab started off at the very beginning with inpatient rehab, but still transitioned over into outpatient rehabilitation. Later on, I worked in a different environment that was still orthopedics, but there was still a huge overlap with concussion rehabilitation and vestibular rehabilitation that I was seeing in that type of outpatient environment as well. And then that transitions me here, and now 100% with vestibular rehabilitation, and it's a great place to land and continuing with vestibular.
Yeah, and you joined the AIB family. What has it been, 6 months now you've been on board with this? Something like that?
Actually, I think I'm climbing up on 8 months now that I've been with you guys. Yeah.
8 months, and it's been an incredible journey. So a little bit of background just for some of our listeners that may not be physical therapists by training or may not have some of that expertise, but that may be more otolaryngology, neurology, and audiology. A little bit, could you give us kind of a background of the wide variety of specializations within physical therapy, from ortho to neuro and vestibular, and kind of what it's like for PTs coming out of school? How do they decide what to specialize in? Could an ortho specialist treat a dizzy patient? Could a neurospecialist treat an ortho patient? A little bit of I think, just some information on that, the specifics of the therapist's journey into specialization, and how you guys kind of cut that up as a profession.
Yeah, absolutely. That's a great question. And when we come out of school, PTs, we say we're generalized across the board, and we can come out and treat, and we're qualified to treat a variety of different types of patients that are going to come through the door. But if we want to transition and specialize into that area, there are residency programs in the United States that are one neurologic residency program. So the direction that I had gone. There's also specialization in orthopedics, sports, as well as women's health and pediatrics and geriatrics. And so after going through different kinds, you don't have to actually go through a residency program to sit for the board exams to become a certified specialist. And so I'm certified through the APTA for the board certification. And you don't have to, like I said, have a residency training, but you do have to meet criteria to be able to sit for that board certification to be a certified specialist. And of course, when you get all these different kinds of patients. And so if you're an MD out there, an ENT, and you have somebody that you're wanting to specifically send to a specialized person, if you have somebody that is neurologic trained and a board certified neurologic specialist, well, you know that they've gone through more extensive training specifically for that dysfunction. If we don't have that training, it doesn't mean that somebody might not know what they're doing, because like I said, through school, we get introduced to all of those different categories. It's just, if you find somebody that has further training in that area, they went through additional training, coaching, just residency, just like any other medical field went through additional training for their residencies.
So, Ali, speaking kind of in that same realm, help give us from a PT's perspective, how important is a multidisciplinary care team for the dizzy patient, and how, from your perspective, does it benefit the patient to have an otolaryngologist, a neurologist, an audiologist, a physical therapist, an occupational therapist? Speak a little bit about that dizzy patient's journey to wellness, and who ideally would make up that care team for the generalized, we'll call them, dizzy patient.
Yeah. And first and foremost, 100%. Yes, we need a multidisciplinary team to treat the dizzy patient. This cannot just be done by one person. And the more people that are specialized and can assist with treatment of these patients, the better outcome these patients can have. My experience started all the way back in inpatient rehab, and working in the hospital. Right out of the gates, I had access to neuropsych, PT, OT, speech, the MD, the physician, the nursing, the CNA, and psychology, and everybody overlapping and really working together as a team in unison. And then as a transition, specifically the outpatient dizzy patient now, if we have somebody that's coming in, let's say my dizzy patient who has a concussion, and I'm not going to be able to specifically treat all of the different areas that somebody with a concussion who is dizzy might need assistance with. They might be seeing the ENT, they might be seeing physical therapy, but if I also have somebody that has specific ocular problems that maybe they need some kind of prisms or acuity checks, I'm going to be making that referral out to ophthalmology. Or if there's cognitive deficits that are also underlying and these memory and cognitive problems need to also be addressed, I'm referring out to speech therapy. So in the outpatient world that we're experiencing now, I have my concussion patient this is just an example, that might be seeing the ENT, and this actually is true with most of my patients now. So they're seeing ENT from after their concussion. They're seeing audiology. They're seeing physical therapy. But then I'm also sending them to ophthalmology and speech. And so that I need all that communication so that we're all working in our realm to be able to treat the patient, because we cannot all do everything. And I only have a certain amount of time with one patient. Audiology only has a certain amount of time. And same thing with ENT. Everybody is so limited with how much time we get with these patients, and we need to be able to work together so that they get the best outcome.
So, Ali, the AIB approach to patient care, now speaking kind of specifically about our clinic and how you guys operate things within the AIB headquarters. We obviously put a patient through comprehensive neurodiagnostic equilibrium studies prior to any rehabilitation or consult with a physical therapist. Could you speak a little bit about, if I'm a dizzy patient and I come into AIB or an AIB equivalent, what's my journey like? Do I have a diagnostic workup and then rehab? Is it kind of a co-treatment type of a situation? Walk me a little bit through the dizzy patient's journey at AIB, at our rehab and diagnostic clinics.
Yeah, absolutely. So it is a little bit of combo at first. Someone's coming in and they're seeing the diagnostic team. Where I want to say a little bit of combo of both is that we do collaborate and we do pull me into the evaluation rooms and we've had discussions together. So let me back up first and foremost. So when the patient's coming in and they're getting referred over to the audiology team and going through the neurodiagnostic studies, they're going to complete all of those assessments. And then if at that evaluation, they might pull me in, depending on what's going on. And if the patient might be a good candidate for rehabilitation, I might come in and give one-on-one consult with the patient as well, depending on the scenario and if they need me. And I'm more than willing to go ahead and come in and chat with the patients and help out with that transition. Now, what's great about having the patients come in and go through the neurodiagnostic testing is we get all of that detailed information of their vestibular system. And if they're what the impairments may be, what the write-up is, what the recommendations are for physical therapy, if they're recommending balance training, if they're recommending vestibular training. And so let's take, for instance, someone that might have an uncompensated unilateral vestibulopathy. And that diagnostic testing gets that concrete evidence of that unilateral vestibulopathy. Now, the patient, let's say they might be a little bit hesitant to rehab, but this is such a great prognosis and the patient really could be an excellent candidate and is an excellent candidate to come in for physical therapy. So that's when the audiology team might come and grab me, give me a little rundown, and together we'll go in and talk over the results with the patient. And that's where I come in. I can also talk to them about their prognosis, what I would prescribe in their vestibular rehab, and overall what our expectations are as a team. And then after that, we'd go ahead and set them up with physical therapy. And all the physical therapy evaluations are then 1 hour long assessments. And then from there, depending on what's going on, their plan of care is decided. Will they just come for a couple weeks? Do I need to see them for a more prolonged period of time? It really depends on what's going on with the patient and what diagnosis we're really looking at.
Yeah. So would you say that, your strong belief, having now had the access to the technology and the specific diagnostic testing, that's not something that most PTs have access to with most dizzy patients. Is that correct?
That is correct. Yeah. I before coming to AIB, I might have a patient that comes in and says, "Oh, I had a rotary chair testing done," and that's happened pretty frequently in the past. Somebody that had gone to an ENT and they had come in and said, "Yeah, I had the rotary testing, but I didn't have access to a full write-up of a neurodiagnostic testing, full test that had been conducted." And now having that access, write up all of the testing that's been completed, that gives me some concrete evidence that I get to already review. It's just as good as when I was in hospital setting and I got the full write up and I could see all the imaging and results and all the testing and blood work that somebody would go through and get all that full write up of what's going on with the patient. But now this is the outpatient world, where we know in the outpatient world, we're all working in different silos a lot of time, and it's hard to get that continuity of care sometimes, or one patient got all this testing done at one different center and then I don't have, and then the other center doesn't have the results. Well, Now I have all of those results from the neurodiagnostics. And then when the patient comes in and they see me, and so let's go back to that unilateral vestibulopathy, and I got to go through, I see what their VHIT was, their rotary chair testing, if they had calorics done, and then I get to look through that. And the patient's already been educated now as to why they're getting sent to physical therapy. And then there's already that buy-in of, okay, they found that this was what was wrong with my vestibular system. That's why I'm going to physical therapy. And now we get to jumpstart right into, okay, you're dizzy. This is what was found on neurodiagnostics. And this is our next approach of what we have to do for physical therapy to get you to be able to bend over and pick up the keys off the floor again, put your shoes on, okay, turn around without feeling like you're having to grab onto the couch. So now the patients know exactly why they need to come see me.
Yeah. So specifically looking at things like compliance and buy-in and improving outcomes, if patients really understand that we have a solution to their problem and that we're not just guessing. Because I feel like a lot of these people coming into rehab or audiology or whomever they're seeing as sort of the entry layer to their care is unless you have a comprehensive neurodiagnostic test battery, a lot of it is, well, maybe it's your blood pressure, maybe it's your blood sugar, maybe it's your eyes, maybe it's your ears. But having that concrete neurodiagnostic information really helps you and therapy in general to be able to facilitate compliance with what you're going to be recommending. And even also, as we know and we teach, there's a lot of psychogenic overlay. There tends to be a lot of anxiety. There tends to be a lot of avoidance in certain things with these patients. So it sounds like allows you as the therapist to be more confident with what the functional diagnosis is going to be and applying exactly the specific plan or modality of treatment to help get that patient their life back more quickly.
Along with that patient buy-in and how that benefits me from the PT side, well, anytime someone comes in as I have dizziness, well, the physical therapy evals I had mentioned are only 1 hour long. So now with the neurodiagnostic write-up completely done for me, and I can review that history, it's not that I'm skipping steps. It helps expedite me to a specific area and make sure I'm double crossing my T's, dotting my I's, making sure my tests are consistent, my outcomes are consistent with what was found with neurodiagnostics, so that my recommendations for VRT are now cohesive with everybody's testing and what everybody has found. And so with the patients, back to the PT evaluation, when a lot of times, if I'm the first person that has seen the dizzy patient, they might spend a long time trying to describe what was going on. They've been through a battery of different types of providers, and they might spend a lot of time trying to figure out how to describe why they're dizzy, what's dizzy. Well, with the neurodiagnostics, like I said, we only have that 1 hour, and now I have this write-up that's providing me with information of this unilateral vestibulopathy. I already know that there's now a vestibular impairment that I'm hunting for in my exam. And so I can do my testing quicker. And then I can also get to my other battery of testing. That's going to be my functional mobility testing, my balance testing, my gait testing, and all of that's going to help support the patients through their insurance. Because we know that Medicare is looking for all those things and check boxes of what we're doing as providers to making sure that we're being able to see these patients. So that's helping me jump to all those things that I need to do to make sure that I'm supporting the patients and their need to be seen for physical therapy.
And, speaking, you guys, particularly from what we see, the rehab provider is put in a really challenging position because they almost end up as, they've got to almost play diagnostics and rehab. Because when a physician, if I'm a dizzy patient and I show up to a primary care doctor and the doctor's solution for me is, well, go to physical therapy, they'll help you get better. The first thing on the therapist's plate is to determine where is this problem coming from, because that's going to influence the type of treatment that's going to be most effective. So I think that when in speaking to our colleagues in otolaryngology, audiology, neurology, one of the best things that you can do for a dizzy patient to empower their care team, to empower the physical or occupational therapist that they may ultimately end up working with, is getting the comprehensive neurodiagnostic evaluation prior to referring out to physical or occupational therapy, not because necessarily the testing is going to solve the problem, so to speak, but it's going to help develop the roadmap for the rehab provider. As Ali put really eloquently and nicely, it's going to help them understand the direction that they need to go with the ultimate goal in mind of getting the patient better more quickly. So do you feel, Ali, do you feel that now being with AIB for 8 months and being immersed in this culture of comprehensive diagnostics and treatment, do you feel like this has elevated your practice in the way that you approach and look at the dizzy patient and helped you kind of learn how to take a more all-encompassing approach? You want to speak to that a little bit?
Yeah, I mean, absolutely. It's definitely elevated my approach. And one of the things that's resonating in my thoughts when I'm listening to this as well is, some of the examples that we're saying are that we're finding evidence in the vestibular testing. Well, you mentioned our psychogenic patients and how it's hard, especially if those patients, it's a psychogenic case and there's not an organic cause of a vestibular dysfunction, and they're being seen by provider, and this patient has been experiencing dizziness for years and no one has seemed to have any answers. Well, the neurodiagnostics has elevated my ability to, and in conjunction with audiology, it's not just me as a standalone. This is the audiology team and myself working together with the results of this being an example of a psychogenic patient where we're seeing, normal on all the write-ups from the neurodiagnostics. But the patient, then we can dive a little bit deeper into, well, what's their psychiatric history? What's history from any kind of past traumas that have happened? And, bringing it full circle back to what we were talking about at the beginning. Well, that brings us back to a multidisciplinary approach where now we've had the audiologist and myself consult. We've gone through the neurodiagnostics. This person's been dizzy for, let's say, 5 years. We're identifying that there's probably a psychogenic component. Well, yes, I can work with them from a functional rehabilitation standpoint, vestibular rehab, but in conjunction, guess what? I need to also bring in our psychologist. I also bring in therapeutic counseling. We need to bring in the cognitive behavioral therapy. And so now we have to bring in a whole nother discipline into that approach so that we can treat those patients. So it's definitely elevated to bringing in that confidence, bringing and empowering us to be able to help these patients that nobody else has been able to identify what could have been the cause before their dizziness.
Yeah. And, it's always interesting to me when you look at, we obviously have a strong belief, a core belief system as an organization of the more people that we can educate and empower to help these patients, the more we can do a better job of helping these patients. So it's always interesting to hear that from a lot of different perspectives, whether it's ENT, again, or neurology or audiology, there's almost, it feels like there's an air of, in a lot of settings, there's an air of competition where the dizzy patient should belong exclusively to the physical therapist, or the dizzy patient should exclusively belong to the neurologist or the audiologist or whatever. And, as you really, really nicely put it there's plenty of these people to go around. The bottom line is the dizzy patient, there are 90 million Americans out there with this problem. They want to get better. Our goal as healthcare providers should be to shorten their journey to wellness by any means necessary. So when you look at the relationship that you have with our audiology team, and the way that you guys collaborate with one another and work together on specific cases or specific certain challenging cases, or maybe even just easy cases, I think is really a model that we try to promote throughout the country, that there needs to be the full continuum of care from diagnostics and evaluation all the way through treatment and demonstration of outcomes. It must be a multidisciplinary approach, because otherwise we're all working with one hand tied behind our back. So kind of on that topic, Ali, when you look at or think of, do you have any other cases that really exemplify the value of the diagnostic piece, or how maybe without that diagnostic piece you would have been going a different direction, or any other specific case examples that you want to walk through really quickly?
Yeah, well, there is another case example of, tagging along that wasn't a psychogenic case that the neurodiagnostic testings were help eliminate out any kind of vestibular dysfunction. And this is a different route. And it was our audiologist, or one of our skilled providers here, that was identifying that there seemed to be something else that was not psychogenic, but this was not vestibular related. And the individual had gone through, first off, the person had been dizzy for a few years. I don't remember exactly how long, and I don't think the individual remembered as well. And she had come here to our facility, and finally, after a few different types of providers, her reports had been dizziness for a long time. And now, going through the neurodiagnostic testing, our audiologist started to, after everything was negative, and all these vestibular testing had been popping up normal, it was one of our audiologists that started asking her other questions, migraine related questions, as well as the cervical related questions. And come to find out, the individual was complaining about neck pain and also jaw pain. And then it was really segued into more of a jaw clenching problem. And that neurodiagnostic helped eliminate out that she's not dizzy because of what's going on in the vestibular system. And our audiologist was able to say she still needs some kind of rehabilitation assistance. We need further assessment, and sent her over, and I ended up assessing the jaw and the cervical spine. And then through a whole nother course of treatment that was more of a manual therapy and dry needling route, eliminated the person's dizziness that she had been experiencing for years. But that neurodiagnostics had helped take all of that off the plate, that we knew that there was an appropriately functioning vestibular system, and that the dizziness was coming from a different cause. And if I had not had that testing done, that would have taken me that much longer to get to that cause, because I wouldn't have been able to, it would have taken me from a raw standpoint of doing bedside assessments to try to eliminate out that there was some kind of vestibular cause for her dizziness, because of the way that she did describe the dizziness. And it had to do with all of her head movements. And it could have muddied the waters a lot, that it would have been vestibular, or was it really a cervical issue? And it really was very muddy. But the neurodiagnostics really helped eliminate that out, so that we could eliminate her dizziness.
Yeah, muddy is a good word for it. You have to be really careful as a physician or ancillary provider that patients come in and they explain things 1,000 different ways. I get dizzy when I move my head like this. Well, when you move your head like that, the inner ear's involved, the cervical spine's involved, the eyes may be involved, the gravitational muscles may be involved. So the first step in really understanding that, like you said, is to segmentally rule in or rule out different systems that may be contributory, and sort of go from there. Because treating a patient with cervicogenic dizziness, or jaw clenching, or vestibular migraine, or vestibular problem, you've got to treat them with a completely different type of rehabilitation. And that's kind of what you and I speak about a lot, is called a diagnosis-based strategy of rehab. So not necessarily taking a shotgun approach of one size fits all, where, oh, you're dizzy, maybe try canalith repositioning or treat BPPV. Hopefully that'll work. Hopefully that'll solve your problems. But rather taking a patient-centered approach that helps review all of the systems involved in equilibrium, see where the problem is, and go from there. Kind of like an electrician might, right? You just don't go in and start replacing wires because the power is out in the house. Rather, you localize, is it this light switch? Is it that light switch? Same thing with a plumber, et cetera, and so forth. So we're basically all just plumbers and electricians, right? But as it pertains to dizziness.
There you go.
So just kind of a couple other thoughts, Ali. When one of the things that's really exciting about AIB's programs is not only do we help practices build business development programs and build diagnostic facilities within their own four walls. We also have a really, really exciting certification program for physical and occupational therapists. Physicians are able to participate in those courses, audiologists. What makes AIBs, the way we do things, from diagnostics and business development, more of the audiology and physician tailored stuff, but also I think that this is represented in our courses. What's so great about AIB education and courses and the way that we go about and approach educating people on dizziness, vertigo, and balance problems?
Yeah, well, and I'll speak to this from a lot of the feedback that we get from our participants, and we make it the information approachable, digestible, and we deliver that information so that the participant can end up transitioning that to their clinical career. And I think that speaks volumes, because there's so many times we're going to study something or watch a video on something or take some kind of continuing education. But I've done it before. I've taken some continuing education, and the takeaways that I wanted didn't transition as well as I wanted to directly to my clinical practice. And it had nothing to do with it was a bad course. It was just, it didn't transition as well as I wanted to make it raw, to elevate me and my practice skills. And I think that that's something that we bring to the table. Everybody that are the faculty with the courses, everybody is so passionate about what they're doing. Everybody is so energetic and so excited to teach this material. And so there's that component. But the other part is we want you to learn, and we're going to make sure that you learn. And we don't mind explaining it 17 different ways to make sure that you, as the learner, get that type of hands-on experience or a deeper understanding. And we open up those doors to a lot of our participants to still reach out to us and contact the faculty afterwards if they need clarification questions on any of the content. So I think that that's also another level that we bring to the table as educators out here in the world of the vestibular world for these dizzy patients, is you don't just take our course and that's it after that weekend. We still have an open communication ability where you can come in and email us and directly talk to one of us on our help desk and clarify any kind of content related questions that you might have from these courses and workshops that we provide.
Yeah, you used a word that I really like earlier. You said approachability. I think it's really, really important when you take a topic that can be really, really esoteric and ethereal and difficult for someone to wrap their minds around and understand. You've got to understand that with vestibular medicine and science, people dedicate their whole career to studying this teeny tiny little organ within the inner ear and these kind of things. And you have world-renowned experts. But if you cannot make the subject approachable for your everyday physician, your everyday physical or occupational therapist or audiologist, it's really challenging to get someone to change their clinical practice and feel confident delivering this service line unless they've had things explained to them. It's like Einstein. If you can't explain something simple enough, you don't know it well enough. I think what makes us really awesome as an organization at AIB, whether we're training physical therapists, whether we're training audiologists or physicians, is we take this really, really big, heavy topic like vestibular that can be super granular and super analytic and super complex, and we're able to explain things and create programs that allow your practitioner that maybe doesn't want to go all the way, doesn't want to go do fellowship and residency and train with world-renowned doctors on how to treat this stuff, but just wants to be able to help the dizzy patient that's sitting in front of them. I think that's what really makes our programs unique, which is all contributed. You dump in the faculty, we've got brilliant staff, we have fun with our workshops, all these different kind of concepts and things. I agree with you completely when it comes to that. So in kind of closing, Allie, any healthcare practitioner, so think audiologist, otolaryngologist, primary care doctor, physical occupational therapist, anybody that's maybe a little bit intimidated or overwhelmed by this topic of dizziness, topic of balance problems, topic of vertigo. What advice do you have for someone who's like, wow, I can really recognize, I see that there's a need for specialists that are equipped to treat this population of patients, but where do I start? Should I call Allie? Should I talk to her? Should I call AIB? Should I get in touch with you? Where might you start? And kind of, you spoke a little bit about your journey earlier, but where might you start if you wanted to kind of begin to build your arsenal of clinical skill sets and business development and kind of understand, if you were a new grad just beginning on this journey, where might you start?
Well, I think I'm going to tie it right back to the workshops and the things that me and you have both been saying about the workshops and the faculty, not just making things fun and approachable, but also, like you said, we're taking information that is so complicated and making it simplified, trying to simplify it so that we're teaching it in the most smooth fashion possible so that it's digestible and reproducible for people. And as simple as it sounds, taking one of the workshops is a great place to start. We have plenty of new grads that come in and take our workshops and feel that they've never even seen someone with BPPV. We've got those very, very beginners from ground level one. And that is completely fine to feel that you are at the very beginning and to jump into a workshop, because the entire time these patients are going to pop up. And what did you say? The statistics of how many dizzy people are in the United States earlier, it was a huge statistic. So whether you're inpatient, you're acute care, you're inpatient rehab, you're going to be a skilled nursing facility, you're in home care, you're an outpatient, and you're any one of those disciplines, you're going to see a dizzy patient. There's no way we're going to get around it. And there's so many different reasons why somebody can be dizzy that if somebody does not want to take a continuing education course or just get exposure to it, then you're just never going to know. It's not as scary as it has to be. And it's absolutely rewarding for patients to feel like they can get up out of bed again and walk the dog again, or bend over and feed their dog a dog treat again and not feel like they're falling over. So step one is jump out there and take a continuing education course, get comfortable with it. See if you have any other physical therapists, if you're a PT or another OT or another PA or ENT that knows somebody that's working in the area, so that you can at least shadow, because we've all shadowed. I've done a lot of shadowing over my career. You've done some shadowing. Me and the audiology department, we shadow each other. And I've been treating for 12 years and I still went over there and spent days shadowing and seeing what they were doing, And so shadowing workshops and getting your feet wet.
Love it. Yeah, love it. So thanks so much, Allie, for your expertise. It's really, I think, for the primary listener that we have are diagnosticians, audiologists, ENTs, neurologists. And we always certainly get a ton of questions about, what does the PT's perspective look like? What do they think about this whole situation? And how do the diagnostics fit into that? So super, super enlightening getting some information, particularly from your perspective, about the journey of the dizzy patient and kind of where you've come from and your expertise and how you fit into the puzzle that is the dizzy patient. We kind of are familiar, our listeners probably are more so with ENT and neurology and diagnostics, but I know there's a ton of value in understanding the lens with which the physical therapist looks through. And your background, obviously your neuro certification, your training and everything, it's really helpful to have you on with us. So thank you so much. Any closing thoughts or anything before we let you go?
No, thank you so much, Joe, for having me. And I'm so happy to be able to be a part of this and expose a little bit more about what we get to do as rehabilitation providers.
Yeah, great. Thanks, Allie. So that was Allie D'Alessandro.
Thank you.
And feel free to reach out, dizzy.com. And for those of you that have been joining us and will join us in the future, we'll look forward to continuing to educate the world, one dizzy patient, one dizzy practitioner at a time. So thanks for tuning in, everyone, and we'll see you next time.